Welcome to OOTO TV, the out-of-the-office investigation from the past into the future of health. This time we're discussing understanding osteoarthritis, causes, treatments, and supplements. I'm enthusiastic to get into this vital topic with you today. This investigation is really crafted for you, designed to cut through the noise and give you the most crucial information from, well, quite a stack of sources.
Absolutely. And our journey today, it's going to be pretty thorough. We'll start by building a solid foundation, really dissecting what osteoarthritis is, right down to the cellular level.
Okay.
Then we'll explore how our activities, our bodies, interact with this condition. And finally, we're going to take a very detailed look at treatments, especially focusing on that burgeoning world of dietary supplements.
Ah, yes, the supplements.
Exactly. We'll analyze the science behind them, and honestly, you might find some surprising facts there. The goal is to leave you feeling thoroughly informed, really equipped with insights you can act on.
That's the plan. We're covering, well, everything essential. The causes, the risk factors, the mechanics of our joints, which is fascinating in itself. Traditional drug approaches and their, let's say, limitations.
All right.
We'll also look at specific exercises that are genuinely beneficial for joint health, and of course that comprehensive look into supplements.
Right.
We're talking creatine, collagen, glucosamine, chondroitin, hyaluronic acid, diacerane, ASU, and turmeric, curcumin. It should be quite an insightful section.
Okay, let's lay that foundation first. What exactly is osteoarthritis? Basically, OA is a chronic condition, often quite debilitating. It's defined primarily by the degeneration, the breakdown, and eventual loss of joint cartilage.
And that breakdown then damages the underlying bones within the joint,
Yeah.
leading to bone overgrowth or what they call remodeling.
Precisely. And the symptoms you typically expect are things like joint pain, inflammation, tenderness, stiffness, and a limitation or even a loss of movement in that joint.
It's incredible when you look at healthy cartilage composition. It's mostly water, isn't it? Like 65% to 85%.
Yeah. Exactly. That water is vital for shock absorption and lubrication. And within that watery matrix, you have the chondrocytes. They're the only cells in cartilage, actually making up just a tiny fraction, maybe 2–5% of the tissue.
But they do the heavy lifting.
They really do. They produce new collagen and proteoglycans, these essential structural components, and they also release enzymes to break down the older, aging tissue. It's a constant turnover.
And collagen, those are the fibrous proteins, the building blocks, with type 2 being the main one in cartilage.
That's right. Then you have proteoglycans, these combinations of proteins and sugars that weave through the collagen, forming this dense mesh that traps all that water. It creates this incredibly resilient, shock-absorbing cushion. It's quite an amazing biological design.
So the OA process starts when that system breaks down. The slow depletion of collagen and proteoglycans.
Yes, and it's important to stress it's not just simple wear and tear. The destruction of that collagen network is, well, it's a complex biological dance. It involves numerous signaling molecules, cytokines, growth factors, and enzymes called proteases.
Like MMP, matrix metalloproteinase.
Exactly. MMP is a key one. It directly cleaves important cartilage proteins like type 2 collagen. And another big player is interleukin-1, or IL-1, which stimulates even more collagen breakdown.
But the body tries to fight back.
It does. That's what's so fascinating. Simultaneously, there's an attempt at compensatory cartilage regeneration, an anabolic process driven by anti-inflammatory cytokines and growth factors. So it's this ongoing battle within the joint, far more complex than just mechanical wear.
Okay, with that picture of the underlying biology, what have been the, let's say, standard pharmacological ways to manage OA?
Well, historically and even currently, pharmacotherapy mainly offers palliative relief. It's about managing the pain and inflammation, not really fixing the underlying problem.
So things like acetaminophen, NSAIDs, those non-steroidal anti-inflammatory drugs, either oral or topical tramadol, or maybe those corticosteroid injections directly into the joint.
Correct. Those are the common recommendations. But here's the crucial point. They are almost always recommended in conjunction with non-pharmacological measures.
Ah, like weight loss and specific types of exercise, like aquatic therapy.
Exactly. So while the drugs provide symptom relief, they're really just tackling the discomfort. It does raise important questions about their long-term impact and, the need for alternatives that might actually influence the disease process itself.
That's a really critical distinction. And those NSAIDs, while offering relief, they come with potential downsides, don't they? Serious upper GI side effects.
Yes, things like gastric ulceration, even bleeding. It sometimes means patients also need proton pump inhibitors, PPIs, just to manage the risk from the NSAIDs.
And there's more, isn't there? The COX class of NSAIDs has also been linked to an increased risk of stroke and myocardial infarction.
That's right. It really highlights the delicate balance required when using these traditional drug approaches. It's not always straightforward.
So, moving beyond medication, how do our daily activities, our movements, how do they fit into the picture of developing and managing osteoarthritis?
It's a really interesting area, actually. Some sports definitely carry a higher risk for OA. We're talking high-impact activities, particularly those involving torsional loading, lots of twisting, turning, sharp cuts.
Like soccer, football, basketball, tennis, even baseball.
Precisely. Those kinds of movements put specific stresses on the joints. But, and this often surprises people, moderate exercise shows a very different picture.
Okay, what kind of moderate exercise?
Things like walking, jogging, resistance training, functional exercises, these activities generally do not increase the risk of OA. In fact, the sources suggest they actually improve strength and mobility in the joints and the muscles around them.
And there was that study on long-distance runners, wasn't there? That had some quite remarkable findings.
Yes, that was fascinating. They looked at runners aged 50 to 72. The key finding: these runners actually had less physical disability and maintained more functional capacity compared to control subjects of the same age who weren't runners.
Less disability, that's significant.
It is. And they also had about 1/3 fewer visits to the doctor. Now, some visits were for running injuries, sure, but not specifically for OA.
And crucially, for OA development itself.
That's the kicker. The study found no significant difference in the development of OA between the runners and the non-runners. Plus, the runners had better cardiovascular health and less overall disability.
Wow. So the conclusion was that a sensible running plan doesn't increase OA risk and can actually benefit the musculoskeletal system as we age. Better bone density, muscle benefits.
Exactly. It really underscores the protective power of staying active, provided it's done appropriately.
Osteoarthritis significantly impacts your overall health and well-being, requiring a holistic lifestyle approach.
You're listening to OOTO-TV with research by author Paul Bulow.
Okay, so beyond specific sports, what other factors increase OA risk?
Well, joint alignment plays a role. For instance, being significantly bow-legged or knock-kneed can put uneven stress on your knee joints over time.
Makes sense. What about injuries?
Absolutely. A history of joint injury or surgery, think meniscal tears or ACL injuries in the knee, definitely predisposes people to developing OA later on. Joint instability, or hypermobility, sometimes called being double-jointed, where ligaments are looser, that also contributes.
And body weight.
Yes, above average body weight is a big factor. It simply puts more continuous compressive force on the joints, especially weight-bearing ones like knees and hips. And finally, general muscle weakness is a problem too.
How so?
If the muscles surrounding a joint are weak, they can't provide adequate support and help maintain proper alignment. This can lead to irritation and potentially accelerate the arthritic process.
So practically speaking, how can we use movement as a form of treatment or management?
The core message is that movement is good. It's fundamentally beneficial because it stimulates the production of synovial fluid.
That's the joint's natural lubricant and nutrient supply for the cartilage.
Exactly. So keeping things moving keeps the joint environment healthier. And the exercises don't have to be complicated. For hands and wrists, think simple claw exercises, not clenching a full fist, just forming a gentle claw shape.
Okay.
Then tabletop movements, working the big knuckle joints. Finger abduction, just spreading your fingers apart and full extension, maybe using your other hand to gently assist the stretch. These can really help combat stiffness.
And for knees?
Simple extension and flexion, kicking your lower leg straight out and then bending it back. You can do this seated, maybe scooting to the edge of your chair to get full extension.
Easy enough. Hips?
For hips, again, simple movements. Seated flexion, gently pulling your knee up towards your chest. Standing flexion, holding on to something for support while lifting your knee. Extension, kicking gently straight back, making sure not to lean forward too much.
Right.
Abduction is kicking the leg out to the side. And rotation, you could do this seated by just swinging your foot side to side, or standing, maybe pretending to squash a bug under your foot, or doing gentle hip circles.
So the key is just gentle, consistent movement.
Absolutely. Keep those joints happy and hydrated.
Now let's shift gears a bit and turn our investigation to a topic that, well, generates a lot of interest and maybe some confusion. Dietary supplements for osteoarthritis. This is where the landscape gets genuinely fascinating and often quite contradictory.
It really does. First, let's clarify what dietary supplements are. They're products taken orally, pills, powders, liquids meant to supplement the diet. This includes vitamins, minerals, herbs, amino acids, things like that.
And crucially, they aren't allowed to make claims about treating or preventing medical conditions, right?
That's a critical point. Manufacturers are responsible for ensuring safety, but the regulatory setup means the burden is actually on the FDA to prove a product is unsafe after it's on the market, rather than the manufacturer having to prove safety and efficacy beforehand, like with pharmaceuticals.
And it's a huge market. You mentioned surveys showing around 69% of OA patients take them. A $30 billion industry in the U.S. alone with something like 90,000 different products.
Incredible numbers. But this is where the controversy comes in. You see conflicting information in the media, which understandably fuels skepticism among doctors. Now, general findings from big systematic reviews do suggest supplements are generally safe to use.
Okay, safe is good, but effective.
That's the million-dollar question. Overall analysis showed moderate and clinically meaningful effects on pain and function, but only in the short term, and importantly, the quality of that evidence was very low.
Low quality evidence.
And many widely used supplements, think glucosamine and chondroitin, did not provide a clinically important effect on knee, hip, or hand OA in these large analyses.
So the popular ones might not be the most effective.
It seems that way based on current robust evidence. Some lesser-known supplements, like Boswellia serrata extract, pycnogenol, and curcumin, actually appear to have larger effects in the short term. But again, the data supporting them is currently of low quality, few studies, small numbers of participants.
And there's an interesting pattern, wasn't there? Supplements with more trials and larger numbers of participants were actually more likely to show small or even non-significant effects.
Yes, that's a crucial observation. And perhaps most importantly, across the board, there was no demonstrable clinical effect on pain and function at medium-term and long-term follow-ups. The short-term relief didn't seem to last or translate into long-term disease modification.
Wow. So this really raises a big question. With such varied, often low quality, and sometimes contradictory evidence, how can you, the listener, navigate this incredibly complex world effectively?
It's a real challenge.
Choosing the type of exercise, vitamins, and supplements for osteoarthritis is critical. Let's start digging into specifics. How about creatine?
Right, creatine. Most people know it for boosting muscle mass and performance, and it also has links to bone biology.
But there's emerging research suggesting other properties relevant to OA, anti-inflammatory and anti-catabolic.
Exactly. The idea is that these properties might create a more favorable environment in the body for muscle and bone growth or recovery. Some animal models showed decreased paw swelling, even analgesic effects similar to NSAIDs.
And in humans?
Human studies have shown it can attenuate or lessen certain inflammatory markers like PGE2 and TNF-alpha after endurance exercise. However, it's not entirely consistent.
Ah, the contrary view.
Yes. Some studies found no effect on certain inflammatory markers after really intense events like Ironman triathlons or resistance exercise. And another study found no difference in various inflammatory markers in older adults doing resistance training with creatine versus placebo. So the picture on inflammation is still a bit murky.
What about bone? You mentioned anti-catabolic effects, preventing bone breakdown.
There's some interesting data there, particularly in older adults. One study in healthy older men found that creatine combined with resistance training significantly reduced markers of bone breakdown, specifically NTX, by about 25%, whereas the placebo group actually saw an increase.
So the combination was key.
It seems so. There's also a suggestion it might help reduce bone mineral density loss in postmenopausal women, again, with resistance training over a year. And some benefits were noted in young boys with muscular dystrophy, decreasing bone collagen equivalents.
So the takeaway for creatine seems to be that it can help reduce bone breakdown, mainly in older adults, but really only when combined with resistance training.
That appears to be the crucial conclusion from the current evidence. The favorable effects on muscle and bone generally happen when combined with an exercise stimulus. It's not magic on its own, but potentially a very helpful partner to exercise.
Okay, let's move to collagen. Huge buzz around collagen supplements.
Yes, and the theory makes intuitive sense. Collagen is the main building block for cartilage, so the idea is that taking it orally might stimulate your own cartilage cells, the chondrocytes, to synthesize more cartilage matrix.
But there's a delivery challenge, right? You mentioned oral glucosamine, often in these products has low bioavailability.
Correct. It undergoes what's called extensive first-pass metabolism in the liver, meaning only about 25% of what you ingest actually makes it into your system in a usable form. That's a significant hurdle.
Despite that, preclinical studies looked promising. animal models.
They did. Essentially, all the in vivo studies in living animals using various types and sources of collagen, concluded that these collagen derivatives had a protective effect on articular cartilage. They either reduced cartilage destruction or seemed to promote its repair.
But then came the conflicting lab studies, in vitro.
Right. This is where it gets complicated. Studies, particularly from a German research group and another in Thailand, looked at collagen hydrolysates that's broken down collagen from various sources in lab dishes. They found these could actually be ineffective or even detrimental to OA cartilage cells.
Detrimental? Why?
It likely comes down to differences in the exact peptide composition of the collagen hydrolysates. Different sources, different processing methods yield different results. It really raises an important flag about the variability between different collagen products on the market.
So what about human clinical trials?
Generally, the published clinical trials found that either oral supplementation or even intra-articular injection of collagen derivatives did seem to improve symptoms and or quality of life for OA patients.
But there were caveats.
Big ones. Most trials were quite short-term and involved relatively small numbers of people. Crucially, there were very few well-designed randomized controlled trials, RCTs, comparing undenatured collagen or collagen hydrolysate against a placebo. And because of that high variability between products, you really can't extrapolate the results from one type of collagen hydrolysate to another.
So the bottom line for collagen is more research needed.
Definitely. We need more independent, high-quality studies, especially long-term, large-scale RCTs, to confirm if there are real benefits and to understand how they might work. The good news, though, is that current evidence suggests these collagen derivatives are generally safe for people with OA.
Okay, next up, glucosamine, another very popular one.
Hugely popular, often derived from shellfish, and the hypothesis is that it stimulates cartilage cells to make more proteoglycans, those water-trapping molecules.
But again, there's a disconnect between lab studies and what happens in the body.
Yes, a significant one. The in vitro studies, the ones in lab dishes that often show positive effects, typically use concentrations of glucosamine that are 100 to even 1,000 times higher than the levels actually measured in people's bodies after they take it orally.
That's a massive difference. And does this translate to conflicting clinical evidence?
It certainly does. Some trials, often company-sponsored and mainly from Europe, using a specific form called glucosamine sulfate, 1,500 milligram, did show a modest reduction in the narrowing of the joint space over time.
But then there was the big GAA trial.
Exactly. The large NIH-sponsored glucosamine chondroitin arthritis intervention trial, or GATITA study. It found that glucosamine hydrochloride, a different form taken alone or together with chondroitin, was no more effective than placebo in slowing down cartilage loss.
Sulfate versus hydrochloride. That distinction seems important.
It might be. Meta-analyses looking at glucosamine overall did find it significantly reduced joint space narrowing, but the effect size was described as modest. So the general conclusion for glucosamine sulfate is that the data is inconsistent and unclear, and any real effect is likely to be small.
And what do the official guidelines say?
Well, based largely on the negative GA trial results, which use the hydrochloride form, major bodies like the American College of Rheumatology and the UK's NICE do not recommend using glucosamine. They cite methodological considerations or simply a lack of evidence of clinical usefulness.
Okay, let's move on to its frequent partner, chondroitin sulfate, or CS.
Right. CS is actually recommended as a background treatment for OA in some European guidelines, like those from ESCEO, with the aim of reducing joint pain and improving function.
And the clinical evidence. Similar story to glucosamine.
Somewhat similar, yes. Long-term treatment might slow down joint space narrowing, according to some analyses. However, that same large GAA trial found chondroitin, like glucosamine hydrochloride, was equivalent to placebo when it came to modifying the disease structurally. Systematic reviews generally point to small but statistically significant effects on structural improvement, but again, with doubtful clinical importance.
But you mentioned earlier there's a crucial distinction here. Highly purified chondroitin sulfate, HPCS.
Yes. This is where the chondroitin story gets really interesting and potentially much more positive. Specific studies looking at highly purified pharmaceutical-grade chondroitin sulfate, or HPCS, showed different results.
Okay, tell me more.
These studies found HPCS was associated with stabilization of the joint space width in the knee, specifically the medial femorotibial compartment. It also showed a significant decrease in the Lequain index, that measure of pain and function, a much larger decrease than seen with placebo, 36% versus 23%.
Stabilization, not just slowing narrowing.
In some studies, yes. Radiological follow-up showed no significant changes in joint space width with HPCS over time, compared to a significant decrease in the placebo group. This strongly suggests HPCS may actually slow the structural progression of knee OA.
You're listening to OOTOTV with research by author Paul Bulow.
And there's more. HPCS consistently improved that Lequien index score and knee pain scores on a VAS scale, and people using it needed fewer painkillers.
What about cartilage volume or bone lesions?
Good question. Patients on HPCS showed less cartilage volume loss and also had lower scores for subchondral bone marrow lesions compared to placebo. These lesions are thought to be linked to pain and progression.
And inflammation.
HPCS significantly reduced synovitis, which is inflammation of the joint lining, compared to paracetamol. It also decreased inflammatory chemokines in the joint fluid.
How does it compare to standard anti-inflammatories like NSAIDs?
One fascinating study compared HPCS, celecoxib, a common NSAID, and placebo. Both HPCS and celecoxib showed significant reductions in pain and improvements in function compared to placebo, and importantly, there was no significant difference between HPCS and celecoxib in effectiveness.
Wow. And does it work for other joints, like hands?
Yes, there's evidence for hand OA too. HPCS was shown to reduce pain and improve hand function and also decrease the formation of new erosive OA lesions in the finger joints.
What about dosage and safety for HPCS?
The typical dosage used in these successful trials was 800 milligrams per day, sometimes starting with 1,200 milligrams per day for more severe cases initially. Interestingly, one study showed taking 1,200 milligrams once daily was just as effective as taking 400 milligrams 3 times a day, and the safety profile looks very good.
Good, how?
A low incidence and severity of adverse events, very similar to placebo. In fact, in some studies, GI side effects were actually more common in the placebo group than in the HPCS group.
So the big takeaway for chondroitin is that the quality of the product, specifically using pharmaceutical-grade HPCS, seems absolutely critical.
It appears to be paramount. This leads directly to that crucial aha moment about product quality in the supplement world.
The difference between pharmaceutical-grade and food supplements.
Exactly. There's a huge distinction. Pharmaceutical CS, like HPCS, undergoes rigorous quality controls. Food supplement versions of chondroitin, however, operate under much looser regulatory constraints. This raises major concerns about their actual content, purity, safety, and ultimately their clinical efficacy.
And there's evidence of problems with these food supplement versions.
Unfortunately, yes. Concrete examples from our sources show studies finding many food supplement chondroitin products simply did not contain the amount of chondroitin stated on the label. Some had virtually none, 0 to 1%, while others might have only 30–45%.
Gosh, shocking.
It is. And beyond just the quantity, quality was an issue too. Many were found to be contaminated things like high levels of insoluble solids or leftover solvent residues from manufacturing. They often contained low-quality chondroitin derived from multiple animal sources mixed together, and perhaps most worryingly, some were found to be cytotoxic to cells in lab tests. One analysis found only 3 out of 10 food supplement products behaved similarly to the pharmaceutical grade in these tests.
This just powerfully underscores how critical it is for you, the listener, to be incredibly discerning and choose thoroughly vetted products if considering supplements like chondroitin. You can't assume they're all the same.
Absolutely not. Understanding osteoarthritis causes and dependencies drives personal mobility and pain management that results in improved mood and reduced anxiety. Now, let's quickly touch on hyaluronic acid, or HA.
Right, HA. It's often found in supplements, but maybe more known for the intra-articular injections, viscosupplementation.
Exactly. But even with the injections, the clinical evidence is inconsistent. Some MRI studies found it no more effective than placebo injections, while other studies, often sponsored by the manufacturers, did show improvements like better cartilage volume.
And there's that puzzling aspect about how long it lasts.
Yes. The HA solution itself is absorbed out of the joint relatively quickly, within hours usually. Yet the claimed pain relief can somehow last for up to 6 months. The proposed explanation is something called viscoinduction, suggesting the HA triggers a longer-term positive biological response in the joint, but the exact mechanisms aren't fully understood.
What do guidelines say about HA injections, and what about oral HA?
The American College of Rheumatology guidelines actually offer no recommendations either for or against intra-articular HA for knee or hip OA, reflecting the uncertainty. And interestingly, oral HA supplements have not been specifically studied in OA patients.
Okay, briefly, diacerine.
Diacerine is a semi-synthetic compound. In the lab, in vitro, it inhibits IL-1, that pro-inflammatory cytokine, and it seems to increase growth factors involved in matrix synthesis. What's promising on paper?
But in clinical studies,
Inconsistent evidence, unfortunately. For HIP-OA, one analysis suggested it decreased joint space narrowing, but it had no effect on clinical symptoms like pain or function. And for knee-OA, studies showed no radiographic evidence of structural effects. So the lab promise didn't really translate clinically.
in avocado soybean unsaponifiables, ASU.
ASU preparations contain phytosterols, plant compounds with suggested anti-inflammatory, antioxidant, and analgesic actions. In vitro, they seem to boost collagen synthesis and inhibit inflammatory enzymes. There were even positive results in a dog model of OA.
But again, mixed results in humans.
Yes. A pilot study in HIP-OA found no overall effect on joint space narrowing, although a subgroup analysis hinted at a reduction in those with already severe narrowing. Another longer-term study found ASU was no more effective and showed no difference in clinical outcomes like pain or function. Although, intriguingly, there were about 20% fewer progressors, people whose joint structure worsens significantly in the ASU group, hinting at a possible but unproven structure-modifying effect.
Okay, finally, let's talk about turmeric and its active compound, curcumin. This one gets a lot of attention.
It certainly does. Widely used as a nutraceutical, known for its anti-inflammatory properties. Lab studies in vitro show it modulates the immune response in ways similar to NSAIDs.
And the clinical evidence, particularly for knee-OA, the systematic review you mentioned earlier sounded quite positive.
It was remarkably positive. That review looked at 10 studies, and all 10 showed improvement in both pain and physical function from baseline levels after turmeric therapy.
All 10. That's consistent.
Very consistent. And in the studies that directly compared turmeric to NSAIDs, there were no significant differences in the outcome scores between the two groups. This strongly suggests turmeric might be similarly effective to NSAIDs for managing knee OA symptoms.
Wow. Similar effectiveness, but what about safety?
That's the other crucial finding. No significant adverse events were reported in the turmeric therapy groups across these studies.
So potentially similar efficacy to NSAIDs, but with a much better safety profile.
Exactly. This suggests turmeric could be a really valuable option, either as a standalone therapy, a monotherapy, or used alongside other treatments as an adjunct therapy, especially for people who can't tolerate NSAIDs or want to avoid their risks.
Are there any catches? Dosage? Formulation?
Yes, those are the remaining questions. Optimal dosing, the best frequency of taking it, and the most effective formulation are still unclear. Curcumin has known bioavailability challenges. It's not easily absorbed by the body. Interestingly, though, one study found similar effect sizes for both high and low doses of a specific curcumin product.
But the higher dose had more side effects.
Yes, the high-dose group had a significant increase in adverse events compared to placebo, even if the effectiveness wasn't better than the low dose. This highlights that there's likely a therapeutic window to consider. More isn't always better, even with something considered natural.
Important nuance. Any other limitations to keep in mind for the turmeric research?
A few, yes. It wasn't always clear if people in the studies were also using other non-drug treatments like exercise. The studies didn't usually classify patients by specific OA subtypes or phenotypes. There was limited analysis based on disease severity, and the follow-up periods were relatively short, maxing out at about 8 months. And generalizability might be limited as factors like race and ethnicity weren't typically investigated.
Osteoarthritis treatments in the form of supplements and exercises exponentially leverages positive mental and physical interaction.
Okay, so that's a lot of detail on supplement. Let's try to synthesize this. What are the major takeaways from our whole investigation into osteoarthritis? Well, I think the first big takeaway is just reinforcing that OA is truly complex. It involves mechanical forces, yes, but also significant inflammatory and metabolic factors. It is absolutely not just simple wear and tear.
Agreed. And the second major theme has to be the power of lifestyle, particularly movement.
Absolutely fundamental. Moderate exercise is consistently shown to be beneficial, even protective. And that finding about long-distance running not increasing OA risk and potentially promoting better overall function is really quite empowering for people who enjoy running or want to stay active.
Plus, those simple practical exercises for hands, knees, hips, they offer tangible ways for anyone to help manage mobility and pain.
Then we get to the supplements, a vast market, definitely full of promise, but as we saw, it's a landscape of incredibly varied evidence.
So for you, the listener, what are the key things to remember from that complex picture?
I think the first is safety versus efficacy. Generally, most supplements appear safe based on current data. But efficacy, that varies dramatically depending on the specific compound and, crucially, the quality of the research behind it.
And that quality point is huge. That stark contrast between pharmaceutical-grade chondroitin sulfate, HPCS, and the often unreliable food supplement versions was a real aha moment.
It really was. It underscores the absolute necessity of scrutinizing product quality and sourcing. You simply cannot assume all products claiming to contain the same ingredient are created equal.
What about specific supplements that stood out? Creatine.
Creatine's evolving role is fascinating. Moving beyond just muscle building, its potential anti-inflammatory and bone health benefits, especially when combined with resistance training, present a really compelling new angle for OA management, particularly in older adults.
And turmeric.
Turmeric's profile looks very promising. That demonstrated efficacy for pain and function, seemingly comparable to NSAIDs in some studies, coupled with its superior safety profile, really positions it as a significant potential alternative or add-on therapy. But as we noted, clarity on optimal dosing and formulation is still needed.
Osteoarthritis requires that you manage your diet specifically for your needs to be mobile, agile, and relaxed. But then, for some of the most popular supplements, glucosamine, especially the hydrochloride form used in GAAP, and traditional non-purified chondroitin, the evidence for significant long-term benefits or disease modification is often quite weak, inconsistent, or even negative in major trials.
Exactly. It highlights that significant gap between market popularity and robust scientific consensus for some products.
So for you, the learner, the message seems to be about informed choices, approaching OA management holistically.
Precisely. Integrating those well-evidenced lifestyle interventions, the right kind of movement, weight management if needed, alongside a really discerning eye for supplements. Always consider the quality of the product and the quality of the research supporting it.